diagnosis, management, and prevention of bronchiolitis. Sean L. Ralston, Alan S. Lieberthal, H. Cody Masner, Brian K. Alverson, Jill E. Bailey, N. M. Gadomski, David W. Johnson, Michael J. Light, Nizar F. Maraca, N. A. Menduncan, Kieran J. Fellon, Joseph J. Sorg, Danette Stanko, Rob, Mark A. Brown, Ian Nathanson, Elizabeth Rosenberg, Stephen Sales, Roman 3 and Cincy, Hernandez, Casio, Pediatrics 2014. This guideline is a revision of the Clinical Practice Guideline, Diagnosis and Management of Bronchiolitis, published by the American Academy of Pediatrics in 2006. The guideline applies to children from 1 through 23 months of age. Other exclusions are noted. Each key action statement indicates level of evidence, benefit, harm relationship, and level of recommendation. The action statements are as follows. Pediatrics, 2014, 134, Diagnosis. 1. Clinicians should diagnose bronchiolitis and assess disease. C. Severity on the basis of history and physical examination. 1. Clinicians should assess risk factors for severe disease, such as age less than 12 weeks, a history of prematurity, underlying cardiopulmonary disease, or immunodeficiency, when making decisions about evaluation and management of children with bronchiolitis. 1. When clinicians diagnose bronchiolitis on the basis of history and physical examination, radiographic or laboratory studies should not be obtained routinely. Evidence quality. B. Recommendation. Strength, moderate recommendation. Treatment. 2. Clinicians should not administer albuterol to infants and children with a diagnosis of bronchiolitis. 3. Clinicians should not administer epinephrine to infants and children with a diagnosis of bronchiolitis. Evidence quality. B. Recommendation strength. Strong recommendation. 4. Nebulized hypertonic saline should not be administered to infants with a diagnosis of bronchiolitis in the emergency department. Evidence quality. B. Recommendation strength. Moderate. Recommendation. 4. Clinicians may administer nebulized hypertonic saline to infants and children hospitalized for bronchiolitis. Evidence quality. B. Recommendation strength. Weak recommendation. Sean L. Ralston, M.D., FOP. Alan S. Lieberthal, M.D., FOP. H. Cody Masner, M.D., FOP. Brian K. Alverson, M.D., FOP. Jill E. Bailey, M.D., FOP. And M. Gadomski, M.D., M.P.H. FOP. David W. Johnson, M.D., FOP. Michael J. Light, M.D., FOP. Nizar F. Maraca, M.D., FOP. A. Duncan, M.D., Ph.D., FOP. FACME, Kieran J. Fellon, M.D., MSc. 5. Clinicians should not administer systemic corticosteroids to infants with a diagnosis of bronchiolitis in any setting. Evidence quality. A. Recommendation strength. Strong recommendation. 6. Clinicians may choose not to administer supplemental oxygen if the oxyhemoglobin saturation exceeds 90% in infants and children with a diagnosis of bronchiolitis. 6. Clinicians may choose not to use continuous pulse oximetry for infants and children with a diagnosis of bronchiolitis. Evidence quality. D. Recommendation strength. Weak recommendation based on low-level evidence and reasoning from first principles. 7. Clinicians should not use chest physiotherapy for infants and children with a diagnosis of bronchiolitis. 8. Clinicians should not administer antibacterial medications to infants and children with a diagnosis of bronchiolitis unless there is a concomitant bacterial infection or a strong suspicion of one. 9. Clinicians should administer nasogastric or intravenous fluids for infants with a diagnosis of bronchiolitis who cannot maintain hydration orally. Prevention. 10. Clinicians should not administer palivizumab to otherwise healthy infants with a gestational age of 29 weeks, 0 days or greater. 10. Clinicians should administer palivizumab during the first year of life to infants with hemodynamically significant heart disease or chronic lung disease. A prematurity defined as preterm infants 32 weeks 0 days gestation who require 21% oxygen for at least the first 28 days of life. Evidence quality. B. Recommendation strength. Moderate recommendation. 10. Clinicians should administer a maximum 5 monthly doses of palivizumab during the respiratory syncytial virus season to infants who qualify for palivizumab in the first year of life. Alavina. All people should disinfect hands before and after direct contact with patients, after contact with inanimate objects in the direct vicinity of the patient, and after removing gloves. 11. All people should use alcohol-based rubs for hand decontamination when caring for children with bronchiolitis. When alcohol-based rubs are not available, individuals should wash their hands with soap and water. 12. About the exposure of the infant or child to tobacco smoke when assessing infants and children for bronchiolitis. 12. Givers about exposing the infant or child to tobacco and smoking. Child bronchiolitis. 13. Clinicians should encourage at least 6 months to decrease the morbidity of respiratory infections. Evidence quality. Recommendation strength. Moderate recommendation. 14. Clinicians and nurses should add on evidence-based diagnosis Treatment and Prevention of Bronchiolitis. Introduction. In October 2006, the American Academy of Pediatrics published a clinical practice guideline diagnosis and management of bronchiolitis. The guideline offered recommendations ranked according to level of evidence and the bronchiolitis is caused by viral lower respiratory tract infection in infants. Bronchiolitis is characterized by acute inflammation, edema, and necrosis of epithelial cells lining small airways, and increased mucus production. Signs and symptoms typically begin with rhinitis, which may progress to tachypnea, wheezing, wails, use of accessory muscles, or nasal flaring. Many viruses that infect the respiratory system cause a similar constellation of signs and symptoms. The most common etiology of bronchiolitis is respiratory syncytial virus, with the highest incidence of infection occurring between December and March in North America. However, regional variation occurs. 90% of children are infected by RSV in the first 2 years of life, and up to 40% will experience lower respiratory tract infection during the initial infection. Infection with RSV mainly or long-term immunity, reinfection. Other viruses that cause bronchiolitis include human rhinovirus, human met, from the American Academy of Pediatrics, norovirus, adenovirus, coronavirus, human and parainfluenza viruses. In a study of inpatients and outpatients with bronchiolitis, 76% of patients had RSV, 39% had human rhinovirus, 10% had influenza, 2% had coronavirus, 3% had human metapneumovirus, and 1% had parainfluenza viruses. Some patients had co-infections, so the total is greater than 100%. Bronchiolitis is the most common cause of hospitalization during the first 12 months of life. Approximately 100,000 bronchiolitis admissions occur annually in the United States at an estimated cost of $1.73 billion. One perspective, population-based study sponsored by the Centers for Disease Control and Prevention reported that figure was 5.2 per 1,000 children younger than 24 months of age during the 5-year period between 2000 and 2005. The highest age-specific rate of RSV hospitalization occurred among infants between 30 days and 60 days of age. For preterm infants, the RSV hospitalization rate was 4.6 per 1,000 children, a number similar to the RSV hospitalization rate for term infants of 5.2 per 1,000. Infants born at 30 weeks gestation had the highest hospitalization rate at 18.7 children per 1,000, although the small number of infants born before 30 weeks gestation make this number unreliable. Other studies indicate the RSV hospitalization rate and extremely duration of RSV season by U.S. Department of Health and Human Services Region Asterisk and Florida, July 2011, June 2012. Florida Region 3, Rose Region 2, Region 6, Region 1, Region 4, Region 5, Region 9, Region 10, Region 8, Region 7, listed by region headquarters city Region 1, Connecticut, Maine, Massachusetts, New Hampshire, Region New Jersey, and New York Region 3, Delaware, District of Columbia. Clinicians should diagnose bronchiolitis and assess disease severity on the basis of history and physical examination. Key action statement 1. Clinicians assess risk factors for severe disease, such as age 12 weeks, a history of prematurity, underlying cardiopulmonary disease, or immunodeficiency, when making decisions about a valve. Key action statement 1. When clinicians diagnose bronchiolitis on the basis of history and physical examination, radiographic or laboratory studies should not be obtained routinely. Evidence quality. Recommendation strength. Moderate recommendation. The main goals in the history and physical examination of infants presenting with wheeze or other lower respiratory tract symptoms, particularly in the winter season, is to differentiate infants with probable viral bronchiolitis from those with other disorders. In addition, an estimate of disease severity should be made. Most clinicians recognize bronchiolitis as a constellation of clinical signs and symptoms occurring in children younger than 2 years, including a viral upper respiratory tract prodrome followed by increased respiratory effort and wheezing. Clinical signs and symptoms of bronchiolitis consist of rhinorrhea, cough, tachypnea, wheezing, wails, and increased respiratory effort manifested as grunting, nasal flaring, and intercostal and or subcostal retractions. The course of bronchiolitis is variable and dynamic, ranging from transient events, such as apnea, to progressive respiratory distress from lower airway obstruction. Important issues to assess in the history include the effects of respiratory symptoms on mental status, feeding, and hydration. The clinician should assess the ability of the family to care for the child and to return for further evaluation if needed. History of underlying conditions, such as prematurity, cardiac disease, chronic pulmonary disease, immunodeficiency, or episodes of previous wheezing, should be identified. Underlying conditions that may be associated with an increased risk of progression to severe disease or mortality include hemodynamically significant congenital heart disease, chronic lung disease, congenital anomalies, 15-17 in utero smoke exposure, and the presence of an immunocompromising state. 19.20 In addition, genetic abnormalities have been associated with more severe presentation with bronchiolitis. Assessment of a child with bronchiolitis, including the physical examination, can be complicated by variability in the disease state and may require serial observations over time to fully assess the child's status. Upper airway obstruction contributes to workup breathing. Suctioning and positioning may decrease the workup breathing and improve the quality of the examination. Respiratory rate in otherwise healthy children changes considerably over the first year of life. 22-25 in hospitalized children, the 50th percentile for respiratory rate, decreased from 41 at 0 to 3 months of age to 31 at 12 to 18 months of age. Counting respiratory rate over the course of 1 minute is more accurate than shorter observations. The presence of a normal respiratory rate suggests that risk of significant viral or bacterial lower respiratory tract infection or pneumonia in an infant is low. 27-29 But the presence of tachypnea does not distinguish between viral and bacterial disease. The evidence relating the presence of specific findings in the assessment of bronchiolitis to clinical outcomes is limited. Most studies addressing this issue have enrolled children when presenting to hospital settings, including a large, prospective, multicenter study that assessed a variety of outcomes from the emergency department in varied inpatient settings. 18-32-33 Severe adverse events, such as ICU admission and need for mechanical ventilation, are uncommon among children with bronchiolitis and limit the power of these studies to detect clinically important risk factors associated with disease progression. 163,435 Tachypnea, defined as a respiratory rate 270 per minute, has been associated with increased risk of severe disease in some studies, but not others. 38 many scoring systems have been developed in an attempt to objectively quantify respiratory distress, although none has achieved widespread acceptance and few have demonstrated any predictive validity, likely because of the substantial temporal variability in physical findings in infants with bronchiolitis. Pulse oximetry has been rapidly adopted into clinical assessment of children with bronchiolitis on the basis of data, suggesting that it reliably detects hypoxemia not suspected on physical examination. 3,640. However, few studies have assessed the effectiveness of pulse oximetry to predict clinical outcomes. Among inpatients, perceived need for supplemental oxygen on the basis of pulse oximetry has been associated with prolonged hospitalization, ICU admission, and mechanical ventilation. 1,634. 41 among outpatients. Available evidence differs on whether mild reductions in pulse oximetry predict progression of disease or need for a return observational visit. Apnea has been reported to occur with a wide range of prevalence estimates and viral etiologies. Retrospective, hospital-based studies have included a high proportion of infants with risk factors, such as prematurity or neuromuscular disease, that may have biased the prevalence estimates. One large study found no apnea events for infants assessed as low risk by using several risk factors: age 1 month for full-term infants or 48 weeks post-conceptional age for preterm infants, in absence of any previous apneic event at presentation to the hospital. Another large multicenter study found no association between the specific viral agent and risk of apnea and bronchiolitis. The literature on viral testing for bronchiolitis has expanded in recent years with the availability of sensitive polymerase chain reaction assays. Large studies of infants hospitalized for bronchiolitis have consistently found that 60% to 75% have positive test results for RSV and have noted co-infections in up to 1/3 of infants. In the event an infant receiving monthly prophylaxis is hospitalized with bronchiolitis, testing should be performed to determine if RSV is the etiologic agent. If a breakthrough RSV infection is determined to be present based on antigen detection or other assay, monthly palivizumab prophylaxis should be discontinued because of the very low likelihood of a second RSV infection in the same year. Apart from this setting, routine virologic testing is not recommended. Infants with non-RSV bronchiolitis, in particular human rhinovirus, appear to have a shorter courses and may represent a different phenotype associated with repeated wheezing. PCR assay results should be interpreted cautiously, given that the assay may detect prolonged viral shedding from an unrelated previous illness, particularly with rhinovirus. In contrast, RSV detected by PCR assay almost always is associated with disease. At the individual patient level, the value of identifying a specific viral etiology causing bronchiolitis has not been demonstrated. Current evidence does not support routine chest radiography in children with bronchiolitis. Although many infants with bronchiolitis have abnormalities on chest radiography, data are insufficient to demonstrate that chest radiography correlates well with disease severity. Atypicity on chest radiography was associated with increased risk of severe disease in one outpatient study. Further studies, including one randomized trial, suggest children with suspected lower respiratory tract infection who had radiography performed were more likely to receive antibiotics without any difference in outcomes. 46.47 Initial radiography should be reserved for cases in which respiratory effort is severe enough to warrant ICU admission or where signs of an airway complication are present. Treatment: albuterol. Key action statement 2. Clinicians should not administer albuterol to infants and children with a diagnosis of bronchiolitis. Action statement profile KAS 2. Aggregate. Although several studies and reviews have evaluated the use of bronchodilator medications for viral bronchiolitis, most randomized controlled trials have failed to demonstrate a consistent benefit from or sharpest adrenergic agents. Several epinephrine key action statement 3 clinicians should not administer epinephrine to infants and children with a diagnosis of bronchiolitis. Action statement profile KS3 aggregate evidence quality benefits B. Avoiding adverse effects lower cost avoiding ongoing use of ineffective medication risk harm. Epinephrine is an adrenergic agent with both sharpest and A receptor agonist activity that has been used to treat upper and lower respiratory tract illnesses both as a systemic agent and directly into the respiratory tract, where it is typically nebulized. Hypertonic saline should not be administered to infants with a diagnosis of bronchiolitis in the emergency department. Action statement. Key action statement 4 clinicians may administer nebulized hypertonic saline to infants and children hospitalized for bronchiolitis. Evidence quality. B. Recommendation strength. Wait. Recommendation. B. Action statement profile KAS4. Aggregate evidence quality. Benefits. Benefit. Harm assessment. May shorten hospital stay if lost. Is 72 age. Key action statement 5. Clinicians should not administer systemic corticosteroids to infants with a diagnosis of bronchiolitis in any setting. Evidence quality. A. Recommendation strength. Clinicians may choose not to administer supplemental oxygen if the oxyhemoglobin saturation exceeds 90% in infants and children with a diagnosis of bronchiolitis. Evidence quality. B. Recommendation strength. Weak recommendation. Clinicians may choose not to use continuous pulse oximetry for infants and children with a diagnosis of bronchiolitis. Action statement profile KAS6. Aggregate evidence quality. Benefits. C. Shorter loss. Decreased alarm. Fatigue. Decreased cost. Risk harm. Cost delayed detection of hypoxemia. Delay in appropriate weaning of oxygen. Benefits outweigh harms. Benefit. Harm assessment. Value judgments. Non-intentional none. Vagueness. Role of patient limited. Preferences. Exclusions. Strength. Non-weak recommendation base. Physiologic data based on the oxyhemoglobin dissociation curve demonstrate that small increases in arterial partial pressure of oxygen are associated with marked improvement in pulse oxygen saturation when the latter is less than 90%. With pulse oxygen saturation readings greater than 90%, it takes very large elevations in arterial partial pressure of oxygen to affect further increases in infants and children with bronchiolitis. No data exists to suggest such increases result in any clinically significant difference in physiologic function, patient symptoms, or clinical outcomes. Although it is well understood that acidosis, temperature, and 23-phosphoglutarate influence the oxyhemoglobin dissociation curve, there has never been research to demonstrate how those influences practically affect infants with hypoxemia. The risk of hypoxemia must be weighed against the risk of hospitalization when making any decisions about site of care. Chest physiotherapy key action statement 7 clinicians should not use chest physiotherapy for infants and children with a diagnosis of bronchiolitis. Action statement profile. Airway edema, sloughing of respiratory epithelium into airways, and generalized hyperinflation of the lungs, coupled with poorly developed collateral ventilation, put infants with bronchiolitis at risk for atelectasis. Although lobar atelectasis is not characteristic of this disease, chest radiographs may show evidence of subsegmental atelectasis, prompting clinicians to consider ordering chest physiotherapy to promote airway clearance. A Cochrane Review 140 found 9 randomized controlled trials that evaluated chest physiotherapy in hospitalized patients with bronchiolitis. No clinical benefit was found by using vibration or percussion 141, 144 or passive expiratory techniques. 148 since that review. The study of the passive expiratory technique found a small but significant reduction in duration of oxygen therapy, but no other benefits. Such clinicians should not administer antibacterial medications to infants and children with a diagnosis of bronchiolitis unless there is a concomitant bacterial infection or a strong suspicion of one. Evidence, quality, recommendation strength, strong recommendation, action statement profile KSA, aggregate evidence quality, benefits, risk harm, cost benefit, harm. Clinicians should administer gastric or intravenous fluids for infants with a diagnosis of bronchiolitis who cannot maintain hydration orally. Action statement profile KS9. Aggregate evidence quality X benefits maintaining hydration. Colitis. One study found that food intake at less than 50% of normal for the previous 24 hours is associated with a pulse oximetry value of 95%. Infants with mild respiratory distress may require only observation, particularly if feeding remains unaffected. When the respiratory rate exceeds 60 to 70 breaths per minute, clinicians should administer palivizumab during the first year of life to infants with hemodynamic, significant heart disease or chronic lung disease or Maturity defined as preterm infants 32 weeks. 0 days gestation who require 21% oxygen for at least the first 28 days of life. Evidence quality. B. Recommendation strength. Moderate recommendation. Clinicians should administer a max MM5 monthly doses of palivizumab during the RSV season to infants who qualify for palivizumab in the first year of life. Evidence quality. B. Recommendation strength. Moderate recommendation. Action statement profile. KS10. B. Palivizumab was licensed by the U.S. Food and Drug Administration in June 1998 largely on the basis of results of clinical trial. The results of the second clinical trial among children with congenital heart disease were reported in December 2003.19 for no other prospect. 5. Randomized, placebo-controlled trials have been conducted in any subgroup since licensure of palivizumab. Review publications provide greater insight into